Hey guys, welcome back to my channel. Today I want to discuss about October 2024 AOGD Bulletin. Okay, as the exams are nearby, so I want to discuss the key points so that I'll complete the whole bulletin in a single video. So first topic in this bulletin is geriatric care, special needs assessment and Pandora box. So basically, geriatrics means all the people. You should write this definition first initially. So the people who are ages 60 or above age are known as geriatric patients. Okay. So that is comprehensive geriatric assessment. Obviously, you can write this easily. Like first thing will assess you'll assess top to bottom like physical, psychological, functional, social, environmental. Then you'll have the problems in that 60 age people. You'll problems. You'll make a list of the problems. Then what to do for the problems, how to solve the problems. You should identify the goals. Then you should make the plan. Then you should make the intervention. After doing everything, you'll review everything. Okay, this is the comprehensive assessment, which is a gold standard. The main problems is morbidity. You everyone know, even our parents or grandparents who are geriatric one, they have many complex morbidities are there, and they're also having polypharma. What is polypharma? At least 4 to 5 medications they are going and buying. Okay, concurrently they are using. That is known as polypharma. These two are main problems faced by middle-aged people. Okay, so there is some index to find out the concerns, main problems. Okay, one is CAG index. CAG index is actually there are two indexes. One is CAG index, and the other one is this thing IADL index. Okay, so first the CAG index, it is for basic activities of daily living. It is for basic activities like first initially you'll get up. Okay, you'll take bath, dressing, toileting, then you'll transferring continence, urine continence, fecal continence, feeding. These are basic needs. For this, it is an index known as CAG index, and Luton Brody instrumental activities of daily living skill is there. So so basically, CAG index is a basic one. You can use that. Okay. Mm, so basic activities, these things, and instrumental activities like you're going outside, shopping, taking medications, taking meals. These are instrumental activities. Okay. Falls risks of this genetic patients they have fall, and some preventive health should be encouraged like vaccines, influenza vaccine, pneumococcal vaccine, herpes zoster vaccine should be taken. Urine incontinence is one of the problem for them, so behavioral therapy should be given. Osteoporosis and osteopenia mainly in females. They have osteoporosis. So preventive screening should be done. Um, okay. Then polypharma, which I already told, more than 4 to 5 medications they are taking. And insomnia, sleep disorders are seeing geriatric patient. Depression is almost half of the patients have depression because they have a reduced cognitive ability, and they lost their independence. Like before, they used to work good. So now, as they're becoming 60 above, they get less cognitive ability. Okay. So main key points I'll tell you. So aging during aging process, older patient deteriorate rapidly. So new signs or any symptoms should be taken in elderly patient as important symptom, and falls are significant cause of disability, and to avoid multimorbidity, so physiotherapy plays an important role. Proper nutrition, preventive health measures should be taken. Urinary incontinence, osteoporosis should be done. Osteoporosis checkup should be done. Second topic of this bulletin is screening for cancers in menopause. So menopause females are risk of cancers, right? So what are the screening protocols should be done? So obviously we know HPV is the main culprit here, so it should be screened. Okay, cytology every 3 yearly, and co-testing for every 5 yearly should be done. Yeah, see, generally for till 65 years we'll do, and if the last reports are everything negative, then you'll stop. If Mm, in last 15 years, okay, you'll stop. If that 65-year-old female came without any history of screening, then you'll do one screening, okay. Mm, WHO has told a 90 70 90 target for immunization. So therapeutic measures are there. If any lesions, we have therapeutic measures like LEAP, large loop excision of transformation zone, cone biopsy, even cryotherapy is there. Okay, then this is a screening for cervical cancer, which I told now. There is a screening for cervical cancer in special situation. What is the special situation? HIV. If she's immunocompromised, then for them, generally screening starts at 30 years. But for HIV patients, the screening starts by age of 25 years. And okay, uh, so every 3 to 5 years, you'll screen it. After 50 years, screening should be stopped after two consecutive negative screening test reports are seen. Risk assessment also should be done for cancers. What are the different cancers she can get? Breast cancer, ovarian, tubal, peritoneal cancer. So personal history should be taken, family history, any ancestry history, okay? Known carrier of any mutation, mammography should be taken for breast. Um, then early menarche, late menopause is the risk factor for endometrial cancer. Okay, so we should see that, and any radiotherapy in the chest. These history should be taken. Yes. Coming to mammography, mammography is includes mediolateral oblique and craniocaudal. Craniocaudal and mediolateral oblique views is taken of each breast. Okay, so the low ambient light is focused, and it should not exceed 20 lux. Should not exceed 20 lux. Okay. So Birard staging, this one. So Birard 0 is incomplete, Birard 1 is negative, Birard 2 is benign, Birard 3 is probably benign. So remember this thing, Birard 1 is negative, Birard 3 is probably benign, and Birard 4 is suspicious, in which again there are four categories, one A, B, C, that way, like percentages of invasion. Then Birard 5 is highly suspicious of malignancy, and 6 is biopsy proven malignancy. If you write this much is enough. Okay. So what you will do if a patient came, when you'll advise her breast screening. Okay, so mammography should be done 1 to 2 yearly basis from the age of 40 years. If she's 40 and above, then you'll ask her to go for 1 to 2 yearly mammography. Okay, till 70 years. Then after 70 years, a decision should be dependent on comorbidities and life expectancy. Okay, it may if she says that I don't want to go yearly or to yearly mammography, then you can offer a 3 yearly mammography. Okay. Um, Mammography is not a sure shot diagnostic one. 20% breast cancers are can miss in mammography as well. Okay. Hmm. Then, if she's having first degree relative with breast cancer, then she should start 10 years earlier than the thing. Like 40 years is the point where you have to start mammography screening, but you should start with 30 years. Okay. There are special situations where breast cancer screening is something affected. Like if the woman with breast implants, if she's having breast implants, what will happen? So breast implants are there, then generally we go for two views in mammography, but in breast implants we'll go for four views. So that because implants is obscures the view, right? Okay. Mm, hmm. Uh, if if the lady came with a report, what you will say? So Birard zero, Birard zero. What is zero? What is zero? Incomplete. Okay, incomplete means something is there which is not visible on ultra mammography. Okay, so Birard zero and even 4 and 5, which are last stages, need biopsy. Okay, why six? Six no need of biopsy? No, six is already a biopsy proven. Why again biopsy? Okay, so that's why Birard is 0, 4, 5. It need biopsy. Okay, then. Postmenopausal hormone therapy can be given. So key points on this is you should go for vaccination, like cancer cervix globally decreased by 90 approach. Okay, then screen and treat is the approach. Colposcopy and biopsy should be advised. Um, Estrogen cream intravaginally can be given. Okay, at least 4 weeks before, so that colposcopy will be good. We can visualize the vessels and all. For people dying of breast cancer, screening mammography is best. Breast cancer screening should be started at the age of 40 and should continue till 70. 40 to 70. If a female came to you, 42 years, you advise her breast cancer mammography, then she'll ask up to till what age shall I need to do this? Then you shall advise her up to 70 years. Okay. Now coming to next topic in this bulletin, vaccinations. See, based on previous topics, can you say what are the vaccinations in menopause? Yes, pneumococcal vaccine, good. Pneumococcal vaccine, good. Then herpes zoster vaccine, very good. Herpes zoster vaccine, good. Then influenza vaccine, good. Okay, remember these vaccines. Others are also being given, but these vaccines are very, very important. Okay, so COVID-19 vaccine is given and in two doses, at least 4 weeks apart, at least 4 weeks apart. Then influenza vaccine, which you have already told. Okay, you will give this thing and more than 65 years of age, especially individuals with chronic medical conditions, then annual vaccinations are given. Every yearly you should take this vaccine. Okay, especially like cardiovascular, pulmonary system disorders, asthma, okay, diabetes, renal, hepatic dysfunction, hemoglobinopathies, immunocompromised. These people should get yearly influenza vaccine. What is a vaccine? It's a live attenuated influenza vaccine. These can be given intranasally also, but above age of 50 years, the topic of discussion only this one. Na? So above age of 50 years, intranasal dose is contraindicated. Okay. Okay. Next, pneumococcal vaccine, you said very good. So it's a streptococcal pneumonia. It's a leading cause of serious illness. There are different types of pneumococcal vaccine, PCV 13, 15, 20. Okay, if one dose of PCV 15 or one dose of PCV 20 should be at least one dose of PCV 15 or else 20 can be given. Okay, 15 or 20. So if PCV 15 is used, administer dose of PPV 23 at least 1 year after PCV 15. Okay, so may use a minimal interval of 8 weeks with the immunocompromised conditions. Then you should see, should you should keep an 8 weeks of interval. What is PPV 23? PPV 23 is also a pneumococcal polysaccharide vaccine. 23, it's a 23 valent vaccine. Okay, see all the numbers are valence. 13 is 13 valent, 15 is 15 valent that way. So people says if you taking 15 with 8 weeks of gap, you take PPV 23 also. Herpes zoster, you said very good. Okay, um, herpes zosters are live attenuated vaccines, and two vaccines have been approved. That's LZV and RZV. What is LZV? Live attenuated vaccine, whereas RZV is recombinant vaccine. Okay, so 2 ml, this RZV is better. So 2 ml, sorry, two doses of 0.5 ml, two doses of 0.5 ml is given 6 months apart. Okay, so all the age of 50 years above, you should take the herpes zoster. This is conclusion. So you'll take COVID-19, shingles, influenza, pneumococcal vaccines. Okay, if you're traveling, then go for hepatitis A, typhoid. Okay. Next topic in this bulletin is sexual health. Sexual health is also important in menopause, right? Because there is loss of sexual function in them. So, what is the response? How to regain them? The sexual response. This should be done. Okay. Um, Basically, estrogen is the one which is helpful for sexual functioning in a woman. So, because in menopause there is estrogen decreasing, the sexual response is decreasing. Okay, because there is no estrogen, there is no vascularity. As there is no vascularity, there is no excitement phase. As there is estrogen plateau deficiency, there is a plateau. Okay, vaginal dryness is there because of estrogen deficiency. Even orgasm intensity and frequency are decreased. Physically, changes are seen. Sometimes because of dry vagina, there is burning and itching seen. Emotional shifts is there. There is emotional roller coaster in menopause. Insomnia is seen. Sexual function is decreased. Okay, there is genitourinary syndrome of menopause. I told you that because of middle age, 50% of the middle age and elderly people have this because of dryness. Okay, that affects the maybe a major or minor vestibule, clitoris, vagina, lower urinary tract as well. Okay, uh, female sexual dysfunction is divided. Okay, mm, classification is there. This classification was given by American Association of Menopause and International Association of Menopause and American Association of Menopause and Urology Association. All follow this female sexual dysfunction classification. So first is sexual desire disorders. Okay, There is a hypoactive sexual disorder. There is sexual aversion disorder. Okay. So first thing is sexual desire disorder. Then see, for a woman to have good sex, first she need to have a desire, right? She need to have a desire. So first thing, there is desire defect in desire. So there is a sexual desire defect. So the female will be hyperactive for the sexual disorder, or else aversion will be up. I'm averse with this sex. In that way, she'll behave. Second thing, if even if she having desire, there is a lack of arousal. She doesn't feel that sex, okay? And orgasm disorders comes in the same thing. If she is feeling that also, if she's just adjusting, then there will be pain because of dryness, that is dyspareunia, vaginismus, other sexual pain disorders, okay? Orgasms will be delayed, or sometimes there will be absent orgasm. So these are different sexual desire disorders. Second part of this classification is frequency of sexual dysfunction. There is low sexual desire, there is poor lubrication, there is dyspareunia. Basically the desire to get to have sex only will be decreased in menopause. Okay. Mm, in a study of in India, almost in South India, there is prevalence of female sexual dysfunction from 68% to 86%. Major reason is urogenital atrophy. Uh, thing is, mm, in this study, they found out because they are opening up to the healthcare profession, because most of the people won't open up to the healthcare profession. That's the thing, because there is no time, there is no knowledge, and there is no ability to tackle the situation. Okay, so um, because of estrogen deficiency, this is causing um, relationship non-hormonal cause also there. Okay. Um, we will learn about management. You will counsel her non-hormonally. You'll ask her some lifestyle changes. Vaginal lubricants can be given for dry vagina. Pelvic floor exercises. Menopause is associated with dysbiosis. What is dysbiosis? Matlab, there is a good bacteria is absent. Okay, so vaginal probiotics can be given. Dilators and stimulators can be used. That is the non-hormonal. Hormone therapy, systemic hormone therapy is given. Okay, pharmacologically also you can go for one is flibanserin. Flibanserin. Banserin. Okay. Basic I told na, she'll have no desire only. For the desire, FDA approved this one. Okay. Flibanserin. Serin. Serin is given for no desire. Serin. Okay. Other drug is bremilantide. Bremilantide. Okay, just remember this. Okay, flibanserin, flipping up that serine. Okay, flipping up that low desire. It is flibanserin. Remember that. Then other treatments are there which need more research. Tibolone, sildenafil, lasers. Lasers are being used, but it has other urinary side effects. Okay, that's about sexual health. Now coming to osteosarcopenia in menopause. Everyone know that osteosarcopenia is seen in case of menopause. So let's learn about. I think if this question comes now, just write about what is osteoporosis. Okay, T score you should write. Normal is see. Uh, every time in our life they'll say that negative. Don't be negative. Okay, every time in our life they'll say don't be negative. Okay, so the in osteoporosis, like T score classification, you should be negative. Okay, so normal is -1 to greater. Normal is -1 to greater. In osteopenia, it is -1 to 2.5. Osteoporosis is -2.5 to below, and severe osteoporosis is -2.5 to fragility fracture. Okay, so -1 or greater, -1 or greater is normal. Okay. I'll tell about this pharmacological management of osteosarcopenia. Okay, you write the physiology, then you'll write the pharmacotherapy. So denosumab, testosterone, growth hormone, and anti-myostatin antibodies. This is very different. I didn't hear this one. So listen, denosumab is it increases the bone mineral density. Okay, testosterone and intramuscular injections are given. This also increase the bone mineral density beneath the lumbar spine. Okay, growth hormone may not cause bone density, cause bone density, but it reduces the fracture risk. Okay, anti-myostatin antibodies, um, along with resistance at exercise, if you give na, it also improves bone health in rats. Anti-myostatin antibodies. Okay, that's it. Next topic is menopause hormone therapy, that is MHT. So in India, it is said that mean age of menopause is 46 years. Okay, MST can be prescribed within 10 years of menopause or less than 60 years. Like, see, some people now, after becoming 62 and all, they feel that, I must have been MHT. So this is a very wrong choice at this age. Better within 10 years of having menopause or within 60 years, you should have MHT if it is better. Okay. So estrogen is given, topical estrogens are given, spray modules are there. So basic estrogen is conjugate estrogen. Okay, vaginal estrogens are given in the form of rings and creams. Progesterone therapy is also given. Okay, so dihydrogesterone 10 to 20 milligrams can be given in cyclical or in continuous form. There is a T-sex. See, T-sex is you will give estrogen and also you'll give begeroxybin, that is SERM, selective estrogen receptor modulator. Okay. Mm, so combination of estrogen and progesterone is there is one capsule. There is a one capsule. This capsule have estrogen with of 1 milligram 17 beta estradiol, and you have progesterone, medroxyprogesterone of 100 milligram. Okay, this can be given. Mm, transdermal doses are there. Transdermal dose you'll give less dose. That is 1 milligram. Na? Here it will be coming 0.05 that way. And norethindrone is stated as progesterone form. Tibolone helps in improving the bone mineral density. Contraindications of MST is all the liver disease, gallbladder disease, any hypertriglyceridemias. Okay, these are contraindications. Basically, OCP's contraindications only you can write. GSM also improves by this thing. Osteoporosis also improves by MHT. Okay. Mm, Follow-up is important. See, we should not use years to years of MST. Okay. Follow-up is important. Vasomotor symptoms actually improves after 3 to 4 weeks. If symptoms are not relieved, then we'll increase the dose. Okay. If the symptoms are relieved, then you'll taper the dose in 2 to 3 years. Okay. If persistent bleeding is then beyond 6 months, then endometrial biopsy should be taken because to rule out malignancy. Mm, See, I told you, only 5 years is the standard recommendation of MHT. So preparations available in India is, I remembered this estrogen validate, Proganova, 2 milligram, that is one preparation, and even Avalon cream is there that can also be used. So conclusion is, women less than 60 years within 10 years of menopause are really safe without risk of breast cancer, and there is moderate risk of cardiovascular risk. Okay, next topic in this bulletin is non-hormonal management of menopausal symptoms. So you have, what are the common symptoms of menopause? Vasomotor symptoms, that is hot flushes, 80%. Genitourinary syndrome, like dryness, dyspareunia, and discharge. Sleep disturbances are seen. Okay, bone health has been affected. Okay, so pharmacological management is paroxetine can be given. I remember paroxetine is Parvati Devi. So Parvati Devi is coming at the correct time to decrease the hot flushes for the ladies been suffering. Okay, so how much she'll give? 10 to 25. Minimum only she'll give. She's God. Minimum dose is enough. Okay, and fluoxetine can be given. Citalin, citalopram, escitalopram can be given. These are all SSRIs. SNRIs are duloxetine, venlafaxine, desvenlafaxine. Just write the names. Gabapentin, pregabalin can be used. Okay, gabapentin is 300. See, GABA. Pregabalin. GABA is 300, pregabalin is 150. Okay. Clonidine can be given 0.1 milligram. Oxybutynin is being used. Fezoli, Fezoline tant. This is a neurokine receptor 3 antagonist. This is 3 milligram per kg body weight is used. This is not actually available in India, and people ask these questions only. Which is not available in India, they'll ask these questions. CBT can be given. Hypnosis has been tried. Weight reduction is better. Lifestyle modifications done. These you can easily read. Hot flushes, you wear loose clothes, dressing in layers, sleeveless blouse, cotton material can help. Okay, avoid the triggers like spicy food. Regular exercise should be done. Yoga is better. Paced breathing. Acupuncture is being studied. Stereo ganglion blocks are given. Phytoestrogens are being studied. Okay. Genitourinary syndrome lubricants can be given, and already told for osteoporosis, denosumab is used. Okay. Libido and sexual function, you can give ospemifene. This actually decreases dyspareunia. Education is important. Okay. Bone health, regular thing is regular checkups is needed. So this is about this thing. I am expecting in this module, I mean in this bulletin, I am expecting a question. If it comes, then I'm expecting that this one, sorry, this one, female sexual dysfunction disorders classification. Okay, and I clearly told how to remember this. First, they lose a desire. First, they lose a desire, right? The desire is lost. Then there is, if there is desire also, that there is no arousal, orgasm problems. Okay, if there is if they are all adjusting and doing also, there is sexual pain problems. Okay, you can write this. Okay, that's it. Thank you.